Mr. David Shun, 65-year-old male history. Acute myeloid leukemia, day 7 post-cytarabine plus daunorubicin. ANC, 120/L, severe neutropenia. Medications, filgrastim, acyclovir, fluconazole. Presentation. I feel shaky and confused. Per family. Temp 39 degrees Celsius at home. Chills X2H. Vitals. BP 92/58, HR 128, RR 28, SpO2 92% RA. Temp 39.4 degrees Celsius physical. Neuro. Confused. GCS 13. Lethargic. Skin. Cold/clammy. Capillary refill 4 seconds. CV. Tachycardic, weak pulses. Labs stat. Lactate, 4.8 millimoles per liter. CR, 2.1 milligrams per deciliter, baseline 0.9. Urine output, 20 milliliters per hour. Diagnosis, febrile neutropenia septic shock. Most urgent initial action. A. Administer acetaminophen. B. Obtain 2 sets blood cultures. C. Start filgrastim. D. Provide warm blankets. Answer B. Blood cultures before antibiotics. IDSA guidelines. Delay compromises pathogen identification. Which finding confirms septic shock? A. Fever 39.4 degrees Celsius. B. Lactate 4.8 plus hypotension. BP 92/58. C. ANC 120/LD. Confusion. Answer B. Sepsis equals life-threatening organ dysfunction. Lactate 2. Shock equals hypotension unresponsive to fluids. Antibiotics must be started within A. 30 minutes. B. 1 hour. C. 4 hours. D. 8 hours. Answer B. Surviving sepsis campaign. Antibiotics within 1 H of recognition. Mortality increased 7.6% per hour delay. Fluid resuscitation order. 30 milliliters per kilogram in S. For 70 kilograms patient. A. 500 milliliters. B. 2,100 milliliters. C. 1,000 milliliters. D. 3,000 milliliters. Answer B. 30 milliliters per kilogram times 70 kilograms equals 2,100 milliliters. Give rapidly via large bore IV. Given rapid bolus, as fast as possible over 15 to 30 minutes. During fluid bolus, BP remains 90/60ths. Next action. A. Repeat bolus. B. Start vasopressors, norepinephrine. C. Administer IV steroids. D. Obtain echocardiogram. Answer B. Persistent hypotension after 30 milliliters per kilogram equals septic shock vasopressor stat. Which medication is contraindicated? A. Piperacillin tazobactam. B. Vancomycin. C. Ibuprofen. D. Acetaminophen. Answer C. NSAIDs mask fever / increase bleeding risk in neutropenia. Acetaminophen preferred. Patient develops hives during vancomycin infusion. Immediate action. A. Slow infusion rate. B. Stop infusion. Administer diphenhydramine. C. Give 4-hydrocortisone. D. Continue infusion. Answer B. Hives equals type 1 hypersensitivity. Stop the infusion immediately. Treat anaphylaxis. Administer diphenhydramine, antihistamine. Assess ABCs, airway, breathing, circulation. If there is wheezing or hypotension, you escalate to epinephrine. Do not restart the infusion. This drug is now on the allergy list. Which intervention reduces mortality in septic shock? A. IV vitamin C. B. Early appropriate antibiotics. C. High-dose steroids. D. Tight glucose control. Answer B. Antibiotics within 1 H reduce mortality by 33%. Other interventions lack strong evidence. Capillary refill greater than 3 seconds indicates A. Anemia. B. Hypoperfusion. C. Hyperglycemia. D. Fluid overload. Answer B. Delayed capillary refill equals poor tissue perfusion, validated sepsis indicator. Discharge teaching priority. A. Restart chemotherapy tomorrow. B. Report fever greater than 38 degrees Celsius immediately. C. Avoid all fresh fruits. D. Stop filgrastim. Answer B. Early fever reporting prevents progression to septic shock in future cycles. Which finding requires airborne isolation? A. Productive cough. B. New vesicular rash. C. Bloody diarrhea. D. Urinary frequency. Answer B. Vesicular rash equals possible varicella/herpes. Neutropenic patients need airborne precautions. Post-stabilization, ANC rises to 500/L, safe too. A. Discontinue antibiotics. B. Remove central line. C. Discharge home. D. Restart chemotherapy. Answer C. ANC greater than 500 plus afebrile 48 age equals low risk for complications. While the patient is safe to leave the hospital, the antibiotics are not discontinued. Antibiotics continue 7 to 14 days. A central line, like a PCC or port, is only removed in febrile neutropenia if it is the confirmed source of infection. Critical safety alerts for AML patients. Highest risk of febrile neutropenia, greater than 80% incidence. Deadly triad. ANC less than 100 plus hypotension plus lactate, 4 equals greater than 50% mortality. Fever plus neutropenia equals antibiotics in 60 minutes. In neutropenic fever, confusion isn't just dehydration, it's septic encephalopathy. Nurses save lives by starting antibiotics before the lactate climbs. Critical sepsis neutropenia differences. Parameter: febrile neutropenia, sepsis, focus, infection risk, organ failure. Key sign: ANC less than 500 plus fever, lactate 2 plus organ dysfunction. First intervention: blood cultures plus antibiotics. Fluids 30 milliliters per kilogram plus antibiotics. Mortality driver: delay in antibiotics, delay in hemodynamic support. Febrile neutropenia fever kills mnemonic. Fluids 30 milliliters per kilogram now. Empiric antibiotics 1H, e.g. piperacillin tazobactam plus vancomycin. Vasopressors if unresponsive. Evaluate cultures, blood/urine/sputum. Reassess Q15-30 minute, lactate, BP, urine. Keep neutropenic precautions. No fresh flowers, raw foods. Isolate if respiratory/vesicular lesions. Lactate trend, 2 equals sepsis. Line removal if catheter-related infection. Septic shock equals ICU transfer. The difference between Redman syndrome, RMS, and a true anaphylactic reaction of vancomycin infusion. How to tell them apart at the bedside. Feature: Redman syndrome, infusion rate related. True anaphylaxis/allergy, hives. Skin finding: flush/redness, diffuse, flat. Hives/urticaria, raised welts. Timing: usually during or right after a fast infusion. Can happen at any time, even with slow infusion. Mechanism: direct histamine release, non-allergic. IgA-mediated, true allergy. Next dose: safe to give again, just slower and pre-medicate. Never give again, contraindicated.